All right, we are live with discussion number 2 in our Welcoming Spaces series. And my name is Tanya. I'm the community developer here at Elevate NWO. We are live in Home Studio E once again. Thank you for joining us. And joining me today again is Renee Boucher, who works with the Ontario Aboriginal HIV/AIDS strategy. Renee, if you can introduce yourself briefly.
Hi, everyone. So I'm privileged to be invited to join this conversation talking about stigma, and I guess today we're talking about institutional stigma. I've been working in HIV since 1995 and been living with HIV over 28 years, and I've been very involved in activism around the HIV sector for just as many of those years. So welcome, and I look forward to the conversation.
Awesome, thank you. So today we are talking about institutional stigma. Last week we talked about what stigma is and the importance of dismantling stigma in order to create welcoming spaces for people living with HIV. Stigma is still kind of, like the biggest barrier to having a really welcoming and open space for where people living with HIV, or even people who are at risk of acquiring HIV, can feel really comfortable to come into the space, access services, and know that their rights are going to be respected, that their confidentiality is going to be respected, and that they're going to be treated like any other person. So that was sort of the gist of last week's conversation. We talked about a few of the impacts of HIV stigma generally, and then just mentioned that HIV stigma can sort of broadly be broken down into 4 different areas: institutional stigma, social stigma, internalized stigma, and stigma by association. So today we're going to really be focusing in on institutional stigma because it's a big one. And it's pervasive in all our institutions and businesses and private practices and any sort of anywhere that where there's a client service provider relationship, stigma can find its way in there. So we're going to talk about that today, and then next week we'll be looking at the other 3 forms of stigma, which of course, I mean, you can't, in reality, you can't really separate them into strict categories. Of course, they overlap. Of course, you might have an organization that has really great policies and is really progressive and really, harm reduction focused and anti-oppression focused, and has all of these things in place. And you might still have, on an individual level, a person who is, operating in a stigmatizing way. So of course, those things intersect and overlap, but we try to break them down a little bit in order to make it a bit easier to understand. I'm just checking back and forth with what's actually happening on the Facebook Live, just to see if there's any questions. So if I pause here and there, that's why. Okay. So I'm just going to define institutional stigma. And this is a definition that comes from the post that we made on Tuesday. If you haven't seen that post, feel free to go back and take a look at it. But we will sort of be going over everything that was within that post during this time. So if you don't want to, leave the live and go read it now, that's totally fine. And this definition comes from the toolkit that we are using that we are adapting to put these posts together. And that's a toolkit that was produced by the Women in HIV/AIDS Initiative. It's a really good definition. It's a great toolkit. So they define institutional stigma as the stigma that's found within policies, procedures, and cultures of institutions like government, law, healthcare, community agencies, etc. Usually it's unintentional and may stem from people working on old information that might be rooted in the AIDS phobia that was so present in the early part of the pandemic, or maybe misperceiving what it takes to keep staff and clients safe from HIV transmission within a workplace or a residence or a shelter or whatever. So although it may be unintentional, it still has really significant negative impacts on people who are living with HIV and also people who are at risk of acquiring HIV. So some examples that we talked about in the post were things like, shelters requiring their residents to give their medication to staff. And, from an operational standpoint, from the shelter, that might make sense because you don't want people's medications to get stolen or whatever. But from a disclosure standpoint, it can be stigmatizing because what is happening there is then you have a staff member who might not know about that person's HIV status, and they absolutely don't need to know that person's HIV status. They then have control of that person's medications, can see what the medication is, and then we have a disclosure happening. So that staff member now knows what the medication is, or can look it up or whatever, and now knows that that person is living with HIV when that person did not disclose themselves. So yeah, that can be a problem. Businesses offering only a certain range of their services to people living with HIV, thinking that they're coming from like a safety perspective, but maybe not quite understanding where the safety piece is coming in or where the risk is coming in. Special markings on a client's charts or a patient's chart that specifically indicate their HIV status. Again, that's a disclosure issue. So, a person has a right to not disclose their status in most situations, and that has to be respected. Or an organizational policy to share a client's HIV status among team members. Again, we're coming up against disclosure issues and HIV non-disclosure laws. So we do have laws in Canada that dictate where a person is supposed to disclose their status, and those, just like the presence of those laws in themselves is stigmatizing. We can't also talk about institutional stigma without talking about intersectionality and the ways that there are layers of identity and the ways that different identities interact with HIV stigma and actually make it harder for certain communities to access services. And I know, Renee, I mean, I don't want to ask you to speak for Indigenous people as a whole, but I'm sure that you've come up against these things, or you've had, talked to people who've come up against these things. And I'm just wondering if you have any insights around, anti-Indigenous racism and HIV stigma and how those things intersect.
So I think an example that comes to mind is going to a hospital emergency room, and there's I guess you're probably going to hear layers of stigma, but my experience when I've gone to the emergency room is number one, arriving and maybe I'm not feeling well. Oftentimes, people living with HIV might not necessarily connect it to their HIV, which in this case, it wasn't because of my HIV why I was going to the doctor, but I decided to disclose my HIV. And when I did get there, it suddenly, it just felt like I was, the response was different, like in how they treated me. And I actually ended up waiting a little bit longer than expected because people were coming in after, and I know they have a list of priorities when people come in, but this was getting unusual that there were so many people going ahead of me, and I wasn't quite sure what was happening there. But I suspected it may have been because I disclosed my HIV. They didn't know how to deal with me. So when I did finally get back, and actually I heard the infectious disease specialist name called over the loudspeaker to come to the ER for what I'm not sure for what reason, but his name was called. And so when I did finally get back, I was actually there and disclosed that I was taking some medication. And suddenly, it wasn't just because of my HIV, but it was, I suspect again, because of me being Indigenous, they saw me as someone that was seeking drugs because they were going to give me pain medication for whatever reason. And suddenly it became about that. And I was like, oh my goodness, like, you know, it's bad enough that I have to deal with the HIV stigma. Now, because I'm Indigenous, I'm having to deal with that. So it really presented a lot of problems. And I've always looked at those experiences as opportunities to educate. And anytime that does happen to me, so this would be a great opportunity to share that, is that I think it's really important that when we're dealing with or we're seeing that kind of stigma go on, that we take the time to reflect back. Because I mean, I could have left her really upset and angry and just said, oh, I'm never going back there again. But I wanted to come up with solutions and ways that we can address the problem. So, since then, we've been having talks about going in and having having an educational session specifically on those issues, whether it's HIV or whether it's on dealing with people of color, Indigenous people. Like it really has helped open the conversation around that. So I think that's an important thing to keep in mind when you're seeing those kinds of um, how do I say, discrimination, I guess, and stigmatizing behavior from people who are supposed to be providing you a service, but are suddenly you're looked upon as being different.
Yeah. Yeah. And then it almost becomes do you feel like it becomes your job to educate people?
Yeah, it almost feels so. Now whenever I've gone into the emergency room, I always have to, like, I've always got that that experience in the back of my head. And so I've actually tested out the theory where I've gone in and, okay, so say I have a broken arm. Well, really, that has nothing to do with my HIV, right? Uh, so I tend not to disclose that. And I find my services the service is a lot quicker depending on how busy it is. But the service tends to be quicker. But I've seen in the past where I've been open to disclosing my HIV. And again, it's that whole delay on, and I've said to them, I said, I said, if you're having an issue with my HIV, you can certainly ask me any questions you want, because I said I have a lot of experience in doing this work. And it's just, for me, it's an opportunity to be able to educate. But sometimes I get that thing where this is not my job. This is your job to actually have at least a basic level of awareness, like we did last week, where we talked about HIV 101, because we can't assume everybody knows what HIV is. But at least if you're at least in a healthcare setting, that you have a general understanding around HIV.
Yeah. And like, I hear you that like you're able to take it as an opportunity for education and an opportunity for engagement with, or like calling people in to the table to talk about these things. But I mean, you are a really strong advocate, and you've been working at this for a really long time, and you've come to a place where you're able to do that. But a lot of people aren't there, and so when they have those types of experiences, their first thought isn't to educate people; it's to walk out.
Yes, and that brings up the whole conversation around people accessing the importance of them following up and those kind of things. So if they're going to a place that's stigmatizing them and the follow up is required, the odds of them coming back are probably not very good. And so I think it's really important that especially in service delivery, that we understand, or at least have a general understanding of HIV, and to really think as service providers, what's my role in this, and how do I create that welcoming space? Because I think that's a really important part of any organization, where if you're having a discussion around around, I guess, just around universal precautions, that you understand what does that mean, universal precautions. It's universal. It's not specific to HIV. It's universal. And I think that's the thing we need to take into account.
Yeah. Yeah, that universal precautions are actually universal, yes. And you don't need anything special or anything extra when you're working with someone who's living with HIV, particularly if you're not like, I don't know, doing surgery or something like that, that's really going to get you in direct contact with someone's body fluids that actually contain HIV in high enough levels to transmit. If you're just doing a routine checkup, or you're checking someone's broken arm, or like, yeah, you come in because you're feeling ill, and that is, no one's getting into a situation there where there would be any risk.
Yeah, that's correct. Yeah.
Yeah. There was something you said earlier that I wanted to, oh, yes.
Dive in deeper.
Yeah, yes. In terms of experiences, have you had an experience where things could have gone, like could have become stigmatizing, or like somebody had a reaction that wasn't wholly supportive, or that made you feel like they were, didn't know, or and then had that interaction turn around into something that was really positive? Has that ever happened? Or has, like, what makes a positive experience?
I have to give some thought to that. Um,
Yeah.
I can only think in healthcare settings right now, where it was an opportunity. Well, actually, in an educational setting, and I think I shared this with you before, um, where, and this was back in the early days, so I don't know if you'd see a lot of that now. I would hope that the educational institutions have since moved on to educate their staff, but at the time, back in the early 90s, it wasn't so much about me experiencing, but I guess I experienced it secondhand. But when my son was younger, he went into school, and his mother had disclosed to the school counselor that my son's father, meaning me, was HIV positive. My son wasn't positive, I was positive. And some time later, and this is in the wintertime, at recess, my son's tongue got stuck to the monkey bars, and they left him there for like what was probably around 10-15 minutes before they actually came in and did something about it. And so we found out later on, because they had to do an incident report, that the school principal actually had knowledge of me being HIV positive. And he, when I got on the phone, of course, I was very upset. But when I got on the phone with him, he said he had a duty to protect his staff. And I said, "What?" He said, "I had a duty to protect my staff." He said, because of your son. And I said, "Yeah," but I said, "You know what?" I said, "Number one, the school counselor was not supposed to disclose that to anyone beyond himself." And I said, and the fact that he disclosed it to you tells me of people's reaction to my son initially, that somehow everyone seemed to be aware of it and nobody wanted to go near. So, again, that was back in the early days. And when I was coming back at that time to Ontario, I didn't come back to um, shake things up. So I mean, certainly I had a legal case against them, but I took it as an opportunity to tell them that you need to educate yourself, bring someone from an AIDS service organization or somebody who has awareness or doing education on HIV, so that they're aware that so it doesn't happen to somebody else, because really that shouldn't have happened. And I think the positive thing that I took away from that is that people or the staff of that were educated, and my son wasn't traumatized any further, because his experience in school, other than that one incident, was pretty good after that. They didn't treat him differently or anything like that, because they did have somebody come in and talk to the staff and educate them. So that would be my one positive experience that I can think of offhand.
Yeah. Yeah, and I mean, it really, like, this seems to all really just come down to having up-to-date and current information. And if we don't have that, even if we're operating under information that's, 5 years old, the landscape of HIV changes all the time. And so if we don't have that information, we actually aren't prepared when we're faced with a situation. And I think about two experiences that I've heard about with two different doctors. And this wasn't even talking about someone who was living with HIV, but it was talking about PrEP. So for folks who don't know, PrEP it is a short form of pre-exposure prophylaxis, and it's a once-a-day pill that people who don't have HIV can take to prevent themselves from becoming HIV positive if they're exposed to it. So it's like a birth control pill, but for HIV and not pregnancy. You take it every day. And so two experiences with two different doctors that where, one person went to their doctor and this was a gay man, and he went to see his doctor who was like primarily served the gay community in a large urban setting, and went to talk to the doctor and said, okay, I'm thinking about starting PrEP. And the doctor said, oh, okay, you know what? And this was a couple of years ago when PrEP was fairly new. I don't know a lot about that. So, let me do a Google search. And like, while this person was in the office, did a Google search with that person to find out some more information. And then they had a conversation about it and proceeded from there. As opposed to another experience in a small town with a family doctor who, was just a sort of general family doctor. And the person went to go see that person and also asked, I'm thinking about going on PrEP. And the doctor responded with, oh, I don't know much about that. I'm going to have to give you a referral to the infectious disease specialist. So totally different, totally different responses. Both family practitioners, but the level of information and the comfort with even trying to access that information and use, internet, modern tools that are available with us to find this stuff out, just totally different. So, those two contrasting experiences, I mean, this person had a really positive experience and this person felt left feeling like there was something wrong with them, or that they were asking for something unreasonable.
And I think you make a very important point there. I think that's really important that, just in any situation, that we shouldn't always assume that a person is comfortable in sharing that. So if somebody is disclosing their HIV versus not disclosing, in the case of disclosing, that's a very big thing for someone to do that's living with HIV. That's very private information. It may be very sacred to that person. And if they're feeling like that experience, like in the example you just used, is being treated in such a way that it was like shock and awe, then that's not going to be a very good experience for that person. And it might prevent them in the future from wanting to disclose that. So I think, there's an obligation from any service provision that provides maybe something specific around that they take into account the person living with their experience of that situation. Because, anytime I hear a story like that, my heart, drops, and I just I feel for them, because, I wish I could change that experience for you. But again, this is why you're doing these sessions, is to educate people and help them be more empathetic and understanding to someone's situation around HIV. Because actually, I don't know if you put it in the post, but you had sent me an email earlier talking about the experience of going to a tattoo parlor. Oh, no, it was going to a salon. And their reaction to it. Could you share a little bit about that? Because I thought that was an interesting one.
Yeah, just in talking with with people who provide esthetician services, and being reluctant to do certain procedures or use certain tools on if someone discloses their HIV status, and for and the reason being was for the safety of the staff and potentially for the safety of the person living with HIV if there was a they didn't want to expose any routes of potential infection, any type of infection. And I think that really comes from a bit of a misunderstanding of the transmissibility of HIV, and like what it takes to keep people safe. And really, and again, with the universal precautions, if people are following those things and they're properly sterilizing their equipment, and there's no risk. There's no risk of transmission, and you're using gloves anyways. That's enough, and also that when it comes to disclosure, people don't have to disclose their HIV status in most situations. So, and lots of people who are living with HIV don't know that they're living with HIV because they haven't been tested yet. So there's that question, or that like requirement of disclosure, or asking that question on an intake form is not actually that useful, because you don't know who isn't or is HIV positive necessarily. Even if you're getting tested regularly, there's always a chance that you could have become positive and not know it yet. There's no requirement, really, no legal requirement for someone to disclose their status. And if someone does disclose their status, the likelihood is they're on treatment. They've been living with HIV long enough that they're comfortable to share their status, and they're going to be undetectable, most likely, or there's a much higher chance that they're going to have achieved an undetectable viral load, and there will be no risk of transmission anyway. So it doesn't really give you any useful information. But I have seen people living with HIV have a form like that, have to fill it out, get to that question, and freeze. Because I don't want to tell this to this person. I don't want to tell my massage therapist. Why do I need to tell my massage therapist? They're not giving me a blood transfusion.
Yeah, that's right.
So then it puts you in this really awkward ethical space.
Yeah, I think that's a really good example of why some of these things really there's no requirement or there's no need for that, because oftentimes when I'm doing education, we talk about transmission and understanding or people's understanding of transmission, and sometimes it can be challenging to educate people around why you shouldn't be doing something. And again, when we're talking about universal precautions, that sometimes gets lost.
Yeah.
And so I think what you're doing or what we're doing is creating more awareness so that people can be more aware of their own attitudes when it comes to a situation where you might be put in a situation where you're not sure what to do. And it's always just think about what universal precaution means and take it in that context versus stigmatizing a person. And suddenly, I think there was an example too around like, okay, so if you did find out someone was HIV positive, changing your whole procedure, why would you do that? You should be doing it anyways, regardless, right?
Yeah.
And now suddenly, because this person disclosed, which really is a huge gift to you, that you should not be changing those procedures because of this person disclosing. You need to stick to what universal precaution means that everybody,
Yes. Like, I guarantee that everyone who's ever provided a service to the public has provided a service to someone who's living with HIV and they didn't know it.
Yeah, unknowingly, yeah.
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 Absolutely, 100% guaranteed. So, yeah, do you really need to know that person's status in order to provide a service to them?
Yeah.
Yeah. I'm sorry if you can hear, my kids are home from school and they're playing video games. So I don't know if you can hear noise in the background, but.
No, not really.
Okay,
Once in a while, but nothing, nothing really loud.
okay, good, good. You hear the occasional scream. That's what's happening. There was something else. Oh, yes. When we were talking about intersectionality before we started the call, we were talking about the differences between living on reserve and living off reserve, and the difference in attitudes and knowledge, and what happens sometimes when people are moving back and forth from reserve to urban settings.
Yeah, so for the last 20 some years, I've been doing education on reserve and sharing my experience of living with HIV. But a lot of the attitudes at the time would be, well, that's a gay disease, or we don't have HIV here because we're such a small community and we're isolated. So the odds of us having HIV are very, very unlikely. And so, like, hearing a lot of these different messages uh, and if you were to test positive, if you were living in your community, then if you move into a place like Thunder Bay or some more urban place, those things might come with you, and your chances of either considering to go get tested if you're not aware of how HIV is transmitted, and you find yourself in a situation where maybe you were at risk for HIV, suddenly that those those inaccurate messages can have an impact on you making the choice to actually, should I go and get tested because I may have been exposed. Or another scenario, maybe you tested positive for HIV, you've moved to the city now, and now the likelihood of you accessing services might be less because you're afraid of being stigmatized. So I think it's really important. Um, as an Indigenous person living with HIV, I've learned this over the years, that you need to educate yourself about your own about your own I don't even know how to frame this, about your own experience of living with HIV, about your own self-care, because you know it, it's important to be aware of the things you might come across, and recognize that some attitudes that you might experience are not yours to own. There's somebody else who needs to educate themselves. So the example we used about somebody going in to an emergency room, some people I know disclose their HIV. They're open and okay with it, but that experience in itself might be a challenge to somebody who's hearing it and say, oh, suddenly, well, oh, well, I don't know if I want to deal with you, and suddenly you're passed off to somebody else. That stigma is such a huge thing, uh, having to deal with the HIV itself, but being Indigenous on top of that can really make for an unpleasant experience. So I think it's important when we're doing this education that we have that general understanding of the two, or I guess, as you said, the intersectionality, and recognizing how do we um, come up with a solution for that.
Yeah,
So
yeah,
yeah, there's so many things. When I think of my experiences that have, last 20 years of traveling to the communities, and then now living in a more urban environment, I've learned so much, and I've had both good and bad experiences, whether that was in community, like in a smaller community versus a much larger one. And sometimes I I welcome I welcome living in a smaller community with HIV, and the only reason being was because the treatment I got was more personable from my doctor, who was of course, aware of my HIV, um, but they treated you more hands-on versus living in a much bigger community like Thunder Bay, for example. The doctor may have hundreds and hundreds of patients, and their care is not so much hands-on anymore. So I think it's again, it all depends. It all depends on someone's location and
Yeah,
how that works.
yeah. Trying to remember if there was anything else that I wrote down here.
Well, there was something else. The safety around sometimes how, and I found this with HIV that in the early days it came about it became more about self-preservation versus trying to support somebody. And I think even in an institutional setting, sometimes the supervisor or the boss might feel a need to develop policies or procedures that looks at providing more safety for staff. And so I think, um, yeah, wanting to keep people safe from HIV, we need to be thinking about wanting to, again, back to universal precaution, but wanting to keep people safe just in general. And HIV shouldn't just be the one thing that people are thinking about. Uh, they need to be thinking about how do we keep our staff safe, but at the same time, how do we keep our clients safe too? So it should be thought from both perspectives.
Yeah. And safety doesn't, like, safety is a big, it's more than just like, how do I deal with the blood spill? Or, safety is like, is support. Safety is knowing that is feeling safe in like, you're in the physical, mental, spiritual, all of those realms, that's all wrapped up in safety. And so if you're focusing on protocol for dealing with a person living with HIV, then that's not safety for that person at all.
Yeah, that's right.
And that that's connected also to this, in your story about your son. It is this feeling that people have this duty to protect, or this duty to report or share a person's HIV status with other team members or staff members or whoever, when really there's no danger.
Yeah.
Nobody's in danger. Even in a congregate living setting like a shelter, nobody's in danger from a person living with HIV. It's not, Ebola, or they're not zombies. They're people who happen to have a chronic illness, and there's really no danger. And again, with disclosure, it's actually unethical to share someone's status if you don't have their full informed consent on why you're doing that, and why that might be necessary, and with that person saying, yes, in fact, I agree with you sharing my status with this particular person. And again, with that full informed consent, like if somebody says, yes, you can share my status with, like you shared it with the counselor, yes, you have permission to share my HIV status with the school counselor. Well, that school counselor didn't have permission to share it with anyone else, and there was no reason to.
And I
that's
think
something that people misunderstand a lot.
and when I think back to the reasoning and trying to understand the principles reasoning behind, well, I need to keep myself safe. And I'm thinking, well, where was that coming from? Like, why did he feel that need? And yes, I know the school counselor didn't told it, but even though the school counselor may have disclosed that, why did he feel this need? Especially if he had all of the facts. And so when I think about the answer to that, it comes from fear.
Yeah.
It comes from fear and a misunderstanding of why and how. And that's where he was coming from. So, it was just a matter of, well, if you had the basic understanding of HIV and transmission and all of that, then your response might have been different. But
Yes.
because you didn't, that was your response to react in a fearful way, in a stigmatizing way.
Yes.
Yeah.
Yeah. And really, I mean, that fear is at the root of stigma.
Yeah.
And we need to really work. I mean, the people who those of us who are in service agencies who are not living with HIV need to be really aware of when we are having a fear response in response to not having adequate information, so that we can help those of us who are living with HIV, or those of us who are living with a mental health diagnosis, or like any other stigmatizing thing. We need to be able to say, oh, I think I'm having a fear response. I need to figure out where that's coming from, and like not put it on the person that I'm trying to provide service for.
Yeah, exactly. Yeah.
Yeah. And it comes down to also looking at policies, looking at where your policies and practices and procedures might be rooted in fear as well. And we're going to talk more about that in a couple of weeks. So next week, we're going to talk about the other 3 types of stigma. But the week after that, we're going to really get into how to start addressing those policies and procedures, and how to, like, what types of questions that you might want to be asking as an organization to start to look at whether or not you do have any stigmas or any fear-based policies sort of embedded within your organization. Well, we're at 3:45, Renee. We did good today. Do you have any final thoughts?
No, I guess the only thing I can think of to leave people with is, I think we all have an obligation, and for the most part, oftentimes when I'm doing presentations, I'm preaching to the choir. But I was thinking about this earlier, and I was thinking, like when we're talking about HIV stigma, just in general, we need to get it to fall on the ears of people who don't think they're dealing with people living with HIV, because if something doesn't impact you directly, oftentimes we don't make an effort to learn more about it. But I think in general, just because, and I think I said this last week when we were talking about HIV, this is a human illness. It impacts the human being, and we need to, as community members, at least have a general awareness, so that when it comes to learning or dealing with HIV stigma, that we're going to be more empathetic towards it, so that we don't stigmatize. And I think that's where we need to start in addressing this problem, is more education about it, and having these kind of conversations, whether it's on Facebook Live or in community, wherever that might be. I think that's a really good start.
Yes, yeah. And recognizing when you don't know, and that it's okay. It's okay to not know. But it's in how you respond to that not knowing. Like, I don't want to expect people to be totally up to date on every new advancement in HIV treatment all the time. Of course not. But have a background, have a general idea, and ask questions. If somebody discloses to you, ask questions, or say, oh, I don't know much about that. Can you tell me about that? Or can you point me in the direction of some resources? Because of course it's not up to a person living with HIV to educate people who are not living with HIV.
Yeah.
It's our responsibility to seek out that knowledge.
Yeah.
But just asking the questions and just being open to those discussions, and recognizing when we're having a fear response and being able to overcome that to respond with care.
Yeah, so thanks for having me on this one.
Thanks, Renee. Thanks for joining me. It's always really nice to have you. And maybe you'll come back one more time, maybe at the end, the last one.
Yeah.
Okay.
Yeah.
Great.
For sure.
All right. Well, have a good afternoon, and thanks
Okay.
everyone who joined us. And we'll see you next time.
Thanks. Okay. Take care.
You too.